Great. So today's webinar, titled Sharing the Care, the Path to Better Outcomes, is brought to you by Medicaid. Medicaid is a MHPA bronze partner and a longtime supporter of the association and our health plan members. I'd like to thank the entire Medicaid team for putting together today's session. With that, I will go ahead and turn things over to our presenters, Dr. Stephen Marin and Doug Golub, for introductions and today's discussion.
Thanks, Eric, and happy webinar Wednesday to everybody. And Dr. Marin, we're going to start.
So my name is Stephen Marin. I'm the medical director at Partners Health Plan, which is a fully integrated, dual eligible demonstration project in New York State to operationalize and test a very non-traditional model of managed care, and I put that in quotes, for those with intellectual and developmental disabilities. This is a way of looking at IDD from a population health perspective, because when you talk about quality of health of people with IDD, it goes beyond just their medical care. It includes their rehabilitation, behavioral and mental health, often as comorbidities to their primary intellectual disability, social and community and residential services. So this is in fact a mega total cost of care health plan, where we really focus on person-centered care, not just person-centered in terms of person-centered around their immediate health needs, but person-centered in terms of allowing them to live a full quality of life as an active member of family and community.
Thank you, Marin. And I am Doug Golub, founder of Medicaid, which is now part of the Caseworthy family. We are a Caseworthy company. We're also the partner to several MHPA members, especially Partners Health Plan. And we seek to redefine the human services landscape with pioneering technology solutions that empower individuals and amplify the impact of providers. And much of the data that you see from today, except where otherwise cited, comes from the Medicaid Care Coordination Suite in use at Partners Health Plan. So with that, today we'll be sharing the care and talking about the path to better outcomes. And today's webinar Wednesday has 4 parts to it. The first is understanding Health Resource Community Orchestration and how it can be applied in other organizations. The second is demonstrating some concrete examples of how the data was used to improve the integration of care across multidisciplinary teams, ultimately the quality of care and outcomes. The third is to promote examples of how to measure, monitor, and improve those outcomes and quality in the IDD space. And finally, we'll be talking about how artificial intelligence already is, but also will continue to become a powerful assistive tool for managed care organizations. And yes, some of our graphics were generated by AI. You can tell by the number of fingers that people have. But this is what AI thinks a health orchestration looks like. And Dr. Marin's going to walk us through what a health resource community orchestration actually looks like.
I think it's important to note that in September of this year, the National Institutes of Health took a large and important step to designate people with disabilities as a health disparities population. This is the result of many years of work by both the IDD community as well as the community of those that serve people who are medically complex, to really look at whether health disparities are directly related to disabilities. And the determination was that, from the NIH perspective, that this is a population that has very distinct sets of health disparities, and therefore should be the subject of unique population and community-based research. I can tell you from my own experience as a senior physician executive in both a large commercial health plan as well as an umbrella organization over a number of very large Medicaid managed care plans. It's rare that you actually have IDD as a unique stratification. And what over the last number of years of my working uniquely with the IDD community, there are some very unique patterns of risks and conditions that occur in people with IDD that result in secondary issues around utilization, as well as quality of health and quality of care that really require a very distinct segmentation and stratification in terms of the model of care that's applied against them. It's said commonly in the IDD community that the standards of care are not standard for people with IDD. And I can give some specific examples. We'll talk about them in a bit. But I think the most important part of that in terms of today's conversation is the fact that there are very unique and complex health resource communities around individuals with IDD. Let's go to the next slide. You know, the fact is that in the standard, in the general population health, we are increasingly, and again, I'm you know, this is at this point pretty well known in our health plan communities at large, you know, that medical care really only is really responsible for affecting 10 to 20% of outcomes. And it's social factors and environment and behavior. And again, while in the non-disabled population, it's often behavioral health or what we variously call health-related social determinants. In the IDD community, it's functional issues and the relationship between people's functional status, both from a cognitive capacity as well as an interaction with the environment capacity, that can have severe and profound effects on their capacity to both have healthcare stability as well as healthcare improvements. So, you know, we talk about you know, triple aim, but you know, triple aim on a population level, on a distinct community level, becomes particularly important because each of these communities requires a very distinct community-specific, as opposed to person-centered, we're talking about community-centered model of care. The idea behind our approach to the IDD tailored model of care is, of course, using the triple aim. How do we improve the quality of life of individuals? How do we increase the opportunity for them, as I say here, to participate emotionally, socially, and even economically as active members of family and community? We want to improve quality of health across the entire population, but also we want to manage appropriate resource allocation. And because of their complexity, there's often very high levels of what would otherwise be preventable utilization of inpatient and emergency services by people with IDD, because their upstream care is not really IDD tailored. So what we see, again, particularly for people who are medically complex, and I include the IDD community among the medically complex community, and that's not because of their biomedical status, it's because their conditions are, number one, chronic, number two, it results in functional limitations, number three, it requires significant numbers of healthcare resources, and number four, there's significant impacts on family. And those are the four criteria by which you judge medical complexity. So particularly in the IDD community, there's a significant health resource community that has lots of involvement and influence, whether actual, virtual, or even potential, on the variables that influence their health and well-being. In our current systems of practice, particularly for those of us that are hands-on the health plan side, you know, we see that the responsibility for the elements of a patient's care is often apportioned independently among all the different professional disciplines, whether primary care and specialists and case managers and therapists and social workers, who bring their mental model of the discipline, contributes independent insights and decisions about that person's care, but often those decisions are not shared collaboratively among others. And I'll tell you, in the IDD community, polypharmacy is a particular problem because the vast majority, for example, of the members of our plan have anywhere from 6 to 10 plus medications. And as a health plan, we're the only ones who actually have a full view of the patient's entire and actual medication list. It may, particularly when the different members of the patient's health resource community are associated with independent organizations. Next. So, yeah, as I said, this aggregation model can result in conflicting priorities. It's actually well known that if you practice evidence-based medicine for an older adult with 7 to 10 chronic conditions, the evidence themselves has conflicts based in them. So there can be miscommunications, clashes in decisions. Families and caregivers may hear different things from different providers who have different perspectives on their loved ones' needs. And when these decisions are made in isolation, there can be a significant risks of fragmentation and discoordination on the member themselves. Because, you know, just because everyone's at the table doesn't mean they're necessarily connected or coordinated. And interdisciplinary does not necessarily mean integrated. And for the IDD community in particular, there's a particular drive and value in investing in integrated care. Now, this is particularly complicated for individuals with IDD. What you see in front of you is a mind map for a family. It happens to be an older child, an adolescent. But in fact, what we see often is that these adolescents, 18, 20, 21, transition into the adult care system. Our health plan takes care of people with IDD who are 21 plus. And in fact, we inherit these plans because in fact, as an integrated plan, we are actually taking transcendent responsibility across most of these. But our model, as we're going to see next, is really grounded in our unique model of care management. Because in fact it is integration that's the critical success factor. You may have 5 or 6 people on the healthcare side involved in someone's care. You've got their day hab and their rehabilitation and their adult daycare and lots of other aspects of their needs, their social needs, their community needs, their interest in recreation, their involvement in faith-based organizations. We take, again, transcendent look at how we can orchestrate that person's life in such a way that their accommodations are met across the span of their life. So how does IDD care management differ? Because we really focus on person-centered. It's in addition to the person-centered services and supports, we take an active effort in community inclusion and participation, and we have advocacy for independence and self-direction. So the foundation of this model is our PHP model of care management. It's really that we look at their condition as a gap between their current state and an aspirational future state. And then we look at all of the determinants of that current state. And so we don't in fact differentiate social determinants from biomedical determinants. They're all determinants because the determinants are really the variables that are affecting the capacity of this individual to achieve their aspirational future state. And by the way, for some of our members, the aspirational future state is, I really want to be able to go to baseball games because I love baseball. And I know that doesn't sound like the thing that a health plan does, but when you look at the aspirational future state and back off from it, you may discover that in fact, it's the control of their seizure disorder that is in fact impeding their capacity to consistently participate in the things that bring value to their quality of life. So our IDD care management model orchestrates the assessment and planning process for each person across all of these domains.
Thanks. And we're also going to take a look at some of the technology that helps to illustrate exactly the orchestrations that.
Well, and I'm going to introduce, and I'm going to, you didn't let me say, if it wasn't for the unique information architecture in the Medicaid model, which we have not found in other platforms, we'd not be able to realize the vision of this particular care management framework.
Thank you. So today we kind of hope to have an application of data analysis from a process that integrates care management and technology to improve individual well-being and outcomes and show some of the data behind it. One of the advantages that we have is we're able to take a look at populations in managed care, not in managed care, with different diagnoses. Each person's different, but each cohort of individuals has some attributes that we can take a look at. So we studied 2,730 people, some of whom are supported by PHP, some of whom are not. And we studied IDD managed care through Partners Health Plan versus those that are in fee-for-service across the United States. And we tried to compare apples to apples, people that have 2 or more chronic conditions, over 21 years old, enrolled in a Medicaid waiver, living in a community setting or an intermediate care facility. And we have at least 2 years of consistent enrollment so that there's enough longitudinal data to be able to identify if it's working. And so from that, about 40% of our study comes from Partners Health Plan, about 1,112 members that meet all of those criteria. And about 60% of our population comes from other fee-for-service plans where we have access to the claims data and other wraparound data for the services that a person receives. One of the big opportunities that Partners Health Plan recognized early on is the opportunity to reduce the time to connect people to home and community-based services. As a managed care plan that is the front door for individuals that are enrolled, Partners Health Plan, the thesis is that Partners Health Plan could connect people to services faster because Partners Health Plan has the, under their auspice, can authorize different services. And we know how long it takes across the country. Looking at some data, there's an article that we published that's cited showing how IDD sees some of the longest average time that people spend on wait lists, second only to seniors across the country. We also know, looking at it, the budgets and the timing for different services. So we understand across the United States what 1915C waivers look like for individuals in these programs, and the problem that, one of the problems that we're trying to solve. At Partners Health Plan, looking over a 2-year period, so Partners Health Plan officially got the green light to go live in 2016. So we've been collecting data for 8 years now, almost, from Partners Health Plan, and being able to see improvements. And this is one of our favorite slides because it definitely shows that by being able to bypass some of the regulatory oversight, because PHP has those responsibilities, because they are responsible for full claims capitation for individuals. So we studied from 2019 to present how people are connected to new services just by studying people that weren't previously authorized for a service and then they were. How much time did it take to actually get that authorization? How much time did it take for the first claim to come in? So you can authorize somebody to receive a service, but until there's actually a provider who has gone through an intake process and gone through an interdisciplinary team process and actually started providing services, that first data service on that first claim is the measure that we use to understand from interest in a service to actually receiving it such that a provider can bill it. How many days was it? And so we found some significant changes. We were able to study populations in care management that are in managed care and those that are not. So we know the days. A service like respite seemed to be the fastest. There were only 5 members that were identified, but they were able to get their first service 118 days faster than the population that was not enrolled in PHP. We look at folks interested in supported employment, 18 people that were connected to supported employment, some for the very first time while enrolled in Partners Health Plan, were able to do it 68 days faster than the average of folks that were not. Community habilitation, which is supports in home and in the community to tailor to each person's needs and goals, an average of 66 days faster for 89 people at Partners Health Plan because of the efficiencies that the care management model and orchestration brings in. An IRA, an individualized residential alternative, this is a group home. And so we weren't expecting significantly faster numbers there because there's a lot more that goes into connecting people to those services because you literally move in. But even that was about 3 days faster for each person. And then we had some data where it was about the same. Day habilitation, about a day faster. Self-directed services, and there are some other steps required there, about a half a day faster on average, so pretty much the same. Then there was a service that was actually a lot slower, and it's a service that PHP is kind of okay with it being a lot slower. Community pre-vocational services. So this is a service that, Dr. Marin, if you could, a little bit on the pre-vocational side.
I think of it as prepping for your. It's more like job training, and in fact, these programs, which by the way traditionally are being phased out of the IDD community, are things like sheltered workshops or other places, which really, in many ways, marginalize people's capacity to fully participate in sustainable and fully integrated employment.
So not a surprise, that's the one service that people were not connected to faster, and that's the one service that PHP is okay with the result of that. And then we take a look at how to actually measure and monitor. So we've got a couple of case studies around ED visits, around depression and anxiety, breast health, diabetes management, access to preventative care, BMI, and financial outcomes that help to identify from a claims perspective and from a data perspective, how is PHP doing? If you can't measure it, you can't improve it. So we'll start with ED visits and hospitalizations. Dr. Marin, go for it.
Sure. It's the obvious thing here would be to say that there's, if you say you're reducing hospitalization rates after COVID, that's not magic. But if you look at our hospital ratio admits per thousand starting in 2018, you can see we did not have a substantial increase in 2020, 2019 and 2020 or 2021. We were able to, in fact, continue the level of intense care management involvement with our community and have able to have sustained reductions in our hospital admission rates over, even from pre-COVID to quarter three of 2023. People with IDD are admitted 4 to 6 times at higher rates than the general population. It's an important baseline to when you're looking at these hospital admission trends. We use ADT data to inform care managers about ED visits and often make an intervention even during the ED visit to find an alternative to hospitalizations. We analyze visit trends to look at the need for whole person supports and do some significant stratification and targeting, particularly around not just the medical issues, but the social determinants, which are different, by the way, in the IDD community than in the community at large, or their community and residential settings. Preventable readmissions remains a challenge for us, and it's largely a challenge because of the residential issues. So while we have been able to make some modest changes, particularly in this last year, where we had where we actually shifted our transitions of care management model, the fact is, for many people going into group homes in the community, so you can live in your own home or live with a family member, you can go to a group home, which is a little bit less restrictive environment, or you can actually live in a residential facility, which is more like a skilled nursing facility, a long-term care facility. That middle group, which is you see here listed as the IRA, the independent residential, is really the place where there's very little healthcare follow-up. So the fact of the matter is it's much harder for someone being discharged from the hospital into an IRA to meet their 72-hour after discharge goals for their discharge plan. And in fact, I'll tell you, as a health plan, particularly for IV antibiotics, we often authorize an extra day in the hospital because it will end up resulting in a much lower level, which is one of the reasons you're seeing this here, an extra day of intravenous antibiotics, so that we can put the issue, we know that the discharge is coming, and our care manager can actually go to the group home and ensure that the discharge plan can be implemented upon arrival after discharge.
Exactly. We're also going to take a look at depression and anxiety. And when we do, we understand that depression can co-occur with other serious mental illnesses. Depression can co-occur with IDD. Depression can be a comorbidity with anything. However, when you look at people with disabilities, and this is CDC data, what you find, whether it's heart disease, diabetes, smoking, obesity, the different rates, for a disability population, these numbers are almost always higher. They're almost always twice as higher. Which means that the population that we support comes with some extra elements to it that is really important for the model of care and really important to support each person. Looking at some of the data and the tools.
Just hold on. I just want to make a point here, which is one of the challenges that the IDD community faces in a healthcare system that does not have particularly IDD tailored clinical policies and programs is what's called diagnostic overshadowing of their intellectual disability with a mental health disorder. We have found that our frequent flyers, our highest utilizers of hospital services around medical comorbidities often have a secondary mental health condition, but that mental health condition is independent of their intellectual disability. And this is a challenge because once they show up in the emergency room, again, unless there's some IDD tailored policies and programs, or our health plan is able to come and intervene as a result of our intensive care management program, many of these people are automatically admitted and have often extended lengths of stay because of the mental health comorbidity.
Thank you. Some of the data that we look at comes from claims. Some of the data that we look at comes from assessments. Some comes from plans. And a little bit later today, we'll talk about how some of the narratives and AI can actually help to identify and mine even more. So from different assessments, there's really important information that comes out. And we do use the generalized anxiety disorder in certain Medicaid implementations. the GAD-2, the GAD-7, the Patient Health Questionnaire, PHQ-2, PHQ-9, and they can be particularly helpful for the study that we did to identify 10% or 9% for the GAD-2 versus 7 for positive screening for anxiety and depression. Same with the PHQ, we were able to identify between 5 and 8% of members that needed some additional supports and conversation during their whole person supports. In fact, 2.6% of members required further assessment for suicide risk in the study that we did. And this is really helpful because being able to look at a population level and identify who the people are that could benefit from some additional conversation, education, and supports makes a big difference in the overall population being supported.
And what's interesting here is that the prevalence rates for positive screening on the GAD, for example, are not much different than the general population. But
Right.
what this allows us to do is stratify the IDD community in terms of who's at highest risk for some type of exacerbation.
Exactly. So there's a question here about, are we conflating all disabilities with IDD? For that one particular slide, yes, we were trying to, specifically there was a slide here that basically makes the case that people with disabilities are generally at a higher risk. It works for IDD as well, but for this particular slide, this is just national data on all disabilities. The same is true for IDD, meaning that for these populations, especially complex populations, where there is intersectionality, these conditions and these risks become amplified. We also took a look at breast health, and for an IDD population, we were typically, as they say with the scientific method, you start with a hypothesis and then you either prove it or you disprove it. So we started with a hypothesis that for members with IDD, regular mammograms and breast health probably were not as high as the level for the general population. And so when we went on to take a look at that, PHP started and put some different protections in place. Breast cancer screenings, women who are diagnosed with breast cancer who have regular mammograms have a 60% lower risk of dying from the disease in the 10 years after diagnosis compared with women who do not have regular screenings. So not that we needed to make the case for why breast cancer screenings are important, but that's why, one of the reasons. And so the National Medicaid HMO HEDIS score, at least in 2020, was 58.4%. It hasn't moved that much. When we studied our fee-for-service populations, we were getting back numbers from the claims of something like 6%, 5%. And we took it back to the fee-for-service organizations, and they said, yeah, that's actually the numbers we got as well. So we thought the data was bad. Unfortunately, the data is bad, but it's not because it was invalid data. It's because the results are not what they should be. At Partners Health Plan, they monitor this regularly. They've got tools and alerts to make sure that this is happening, set up appointments and transportation for individuals. But they also understand that some of the machinery necessary for a mammography and some of the other ancillary activities related to that mammography create an environment for people where it's not comfortable, and many people don't do it, which is why we see numbers like 6%. At Partners Health Plan, they actually advocated to get the state's Department of Health to be able to look at other alternatives like sonograms, to be able to have a similar effect, but understanding the population that try to solve for this in a different way. And as a result, PHP's members, when it comes to breast cancer screening rates, are at 79%, which is still not high enough. However, it's a lot better than anything else we've found because of the model of care in place. And they look to continuously try to improve that because of the statistics around what early prevention looks like. We also took a look at diabetes management, and 13% of all US adults have diabetes, according to the CDC. And people with disabilities, much to that earlier question, people with disabilities are unfortunately more likely to develop diabetes because of other intersectionality of their different diagnoses. So when we studied the populations of fee-for-service versus managed care, 25% of members in this sample have diabetes, which is higher than the 13% national average, which is to be expected given the criteria of who was in our study. And At PHP, 65% of all members were getting regular diabetes tests, versus 13% for the fee-for-service population based on the claims. And the claims are a pretty good way to tell this. Certain things, when we take a look, for example, at immunizations, claims data is not the best way to figure that out because there are immunizations that are given without claims. But when it comes to mammography and comprehensive diabetes care, rarely is anybody doing that without producing a claim. So it becomes a lot more valid of a measure to take a look at. At PHP, those members with comprehensive diabetes care, we can tell from the claims, is 83% for those people that do have a diagnosis, versus only 28% that are producing the claims for the services for the fee-for-service population. So PHP's numbers are a lot better because PHP's model of care identifies these areas and focuses on them, provides rounds for individuals and reporting to make sure that these numbers get as close to 100% as they possibly can. And so this is a big advantage to the managed care model over a fee-for-service model that's found at PHP. We also take a look at access to preventative care. And for many of the MHPA members, Medicaid Health Plans of America, when you think about preventative care, you think about the wellness visits as one of those items. Many of the members and all of the members at Partners Health Plan, they don't have copays, they don't have coinsurance, they don't have deductibles. Those are not the barriers to care. There are other barriers to care and reasons why, but it's not necessarily financial. And so periodic wellness visits, I think we all understand, help establish health baseline, keep up on preventative screenings, educate members about chronic risks, and build relationships. And so when we look at the PHP population, 90% of PHP members are having annual wellness visits. And this again is another service that rarely doesn't get billed for. So the claims tell a pretty decent picture here of what's happening. Versus the fee-for-service population, only 75% of members were producing claims for annual wellness visits. And that's a pretty big 15% difference. And none of these groups, it's not because they don't have, it's not because of their copays, coinsurances, or deductibles. It's also not necessarily because of transportation. These are generally included in these waivers and programs. But Partners Health Plan is making sure with care management that it's happening for the person. And we can see the difference. And we know what the data shows us when people actually have their preventative care. We know the other factors that follow from that. So this has been really helpful from the PHP side. We also take a look at telehealth trends, and across nationally, there was a big surge in telehealth that happened in Q2 of 2020 because of the public health emergency. And then across the rest of after that in 2021, nationally, we've seen it level off at about 20%, and it hasn't really moved too much from there. This is people using portals and telehealth, et cetera. PHP's done a lot with telehealth services and has some great partners, but when it comes to the actual portal usage itself, through the Medicaid platform, I never really saw that bounce in 2020. However, it's pretty much leveled off to the same level as everyone else at this point. So we push for more portal use, as all vendors do, and try to see those numbers improve. We also take a look at BMI. In 2014, CMS issued the Home and Community-Based Services Settings Rule, primarily for older adults, but also for people with disabilities to live in the community, to live in the most integrated settings of their choice. And that's particularly helpful. When we look at the different settings, these three graphs on the right side go from left to right, from most integrated to least integrated setting. One of the things that we find is that the more integrated the setting, the higher rates of individuals being overweight and being obese. Some of this is the dignity of risk and people's choices to control their own exercise, people's choices to control their own diet. There are also medical factors as well, of course. But what we find is the more integrated the setting, the higher rates of obesity and overweight. And what does that mean? Well, it doesn't mean that integrated settings are the problem, not at all. What it means is understanding that as people move to more integrated settings of their choice, there are opportunities for care management to be aware of some of these results and to help provide additional services like nutrition services,
Yeah.
like recommendations, like education for the members, so that they can live in the most integrated settings of their choice and also have optimal health that is the health of their choice. So
This is one of those social determinants that is a different variable. It's not so much housing insecurity as a social determinant. It's housing context as a social determinant. And as we began to see these trends, we in fact began a benefit offering of an OTC benefit card that allowed people to particularly buy certain types of food. It's only for our members in the community setting. It's not necessary or appropriate for people who living in group or certified settings, but for people who live in community settings, what's listed here as a non-certified setting, we do offer some support around the use of their OTC over-the-counter benefit to get nutritional counseling, go to the fitness, joining a gym, or actually have meals delivered. And we've created a package that allows them to choose from various meal plans that they can use their OTC benefit to use. And we're starting to see some changes as a result of that particular nutritional benefit affecting weight levels and BMI levels in the community population.
perfect. And it comes from being aware of the population level data, right? If you can't measure it, you can't improve it. And then we finally take a look at some of the financial outcomes. So we've stratified for Partners Health Plan everybody into one of three types of settings. Non-certified setting, they live at home, they live on their own, they live with family, they live with friends. A certified setting, an individualized residential alternative, a group home, or intermediate care facility. Technically, sometimes these are classified as institutional settings, but they're not traditional developmental centers at all. Even these are community-based places, primarily for people with who are somewhat medically frail. And so, as you can see by the numbers, the percentage of people in each different type of setting, the largest are people that live in non-certified settings, second largest being certified residential settings. As the settings become more integrated, what we also find is that the overall costs go down, and there's causation versus causality, right? There's also some of the choices and the reasons why people would want to be in certain settings or are in certain settings due to medical need, sometimes pushes people into less integrated settings. Partners Health Plan tries everything imaginable to avoid that for each person and their own independence. But what we find is for each of these settings, when we look at the cost of physical health care, because Partners Health Plan is responsible for the cost of all of the physical health care and also home and community-based waiver services through their capitated rate. What we find here is that generally the costs for people in certified residential settings are about the same for a fee-for-service population and for Partners Health Plan. They're not seeing necessarily savings on the claims there. But if you look at it, specifically the certified residential settings, there actually is a saving. They're spending a lot more. They're investing a lot more in healthcare for each person. And as a result, some of the other home and community-based services, while the total cost of Medicare and Medicaid combined for the individual are about the same, if you look at where the investments are being made, because people are getting their annual physicals, because of the mammographies, because of all of the other services that people are receiving, the medical component is more at Partners Health Plan than people that are not enrolled in managed care. But the overall cost is about the same. There's actually a cost savings at Partners Health Plan for people that live in non-certified settings. But again, the physical healthcare expense is higher, but the other wraparound services end up being lower at the end of the day, in this case, significantly. So we continue to study Partners Health Plan's results and the overall cost for each individual over time when these investments are made. And the data is really promising to show that these investments are absolutely worth it. And
the other part of this is that, part of, again, under the fully integrated model where we are taking transcendent responsibility across the person's whole life, one of the goals that we explore every year as part of our life planning process is the move to a more independent setting. For many people in the intermediate care facilities, that's difficult. They are the most frail and medically complex. But our track record of moving people from certified residential settings to non-certified settings is very good. And for people who end up in the ICFs, as the equivalent of a skilled nursing stay after hospitalization, also are able often to move into the more independent certified residential settings.
Definitely. Next up, we take a look at some other data. So we've looked at claims data, we've looked at some assessment data, we've looked at some planning data that help us identify at a population level. It's 2024. We can't do a good presentation without talking about AI this year, so we will. How can AI become a powerful and assistive tool for managed care organizations? So we start here by sort of, as Dr. Marin talked about at the beginning, the IDD population has intersectionality with many other populations, aging, mental health, other types of disabilities. But we're going to speak for a little bit about why some of the health-related social needs for a population like Partners Health Plan, sometimes one size doesn't fit all. And with Dr. Marin, take it away.
Yeah, no, you know, we as a health plan, obviously, we're looking at the 2024 HEDIS measures. We know that a health-related social needs assessment has been included as one of the measures that we're going to be responsible for, but we're looking at the actual measure that we're required to use. And for a significant number of our population, in fact, almost 40%, who live in group settings, not so much the intermediate care facilities, not the skilled nursing type, but the middle ground. There is no housing insecurity. There is no food insecurity. There is no challenge to transportation because there's a transportation benefit built in. But there are other social needs that are associated with that. Loneliness, by the way, and social isolation being the number one. And also a number of the disparities in terms of social judgments around people with IDD provide a level of stress that often affects their long-term health, their capacity to fulfill. So when we look at social needs screening, one of the things that we've been able to do, and Doug's going to go into some detail in a very exciting way, we're looking at text narrative and analyzing some of the narrative text to help us identify social needs on our own, independent of the particularly required screening that we've been required to for quality measure.
Thank you. So we get to use a little bit of AI, and so like many of you, I go to a lot of webinars, not as good as this one, but I go to a lot of webinars and lots of folks are talking about AI. Sometimes it actually is AI, sometimes it's some of the packaged up stuff that people have been using before. So AI, it isn't new, but it is a lot more available. There's also plenty of challenges with it. But when we think about what AI is versus what it isn't, AI are tools, artificial intelligence or assistive intelligence, in the work that we're doing here. It can learn, it can reason, it can problem solve, it can perceive, and it can use language, much like we people can. And in 2024, the big flavors of artificial intelligence come from generative artificial intelligence, machine learning, and they come in a couple of flavors like images, some of the clip art that we've used today, and speech and sound recognition, text recognition, that's a lot of what we'll be taking a look at, robotics, biometrics, and combination of all of the above. We have a question that's also pretty appropriate to this, which is, without the model of care and the data collection, we can't do any of the work that we're doing. And the question is, for Dr. Marin, can we talk more about the people that are doing care management? What kinds of background do they have?
So we actually have a two-tier care management model. Our care managers are bachelor's trained, and there is a certification program called a QIDP, Qualified Interdisciplinary Professional. But every one of our care managers is assigned to a team that's overseen by a clinical lead who is a licensed healthcare professional, nurse practitioners, social workers, and others. So it's really a two-person team assigned to every individual, and then it's actually less about the person themselves and their background, and more about their willingness to really immerse themselves in the lives of their caseloads, which, by the way, tend to run 30 to 40. And we have incredibly high expectations for their level of involvement. And part of what we have to do at the provider network side is really build a bridge between our care management operation and the provider network that's caring for our particular population. and we encourage and work with our provider network to look at our care managers, not so much in terms of oversight or disease managers, but really as staff augmentation for their practice around the special needs and accommodations of this particular patient group. I hope that answered the question.
Thank you. And specifically these care managers, they're the ones that are logging care notes. They're logging good, bad, or otherwise, whether they can reach a person or whether they can't, whether they've connected people to services and supports. And they're also logging plenty of, an annual assessment and other planning activities. And in that, they're capturing a lot of narrative about the person. We're using that information. They're getting questions, some of which are point blank, right? Do you want to live in a different kind of a setting? Yes or no. Do you want to change your employment? Yes or no. Right? Are you happy with your weight? Yes or no. Right? There are some questions that they're asking that are pretty, binary, straightforward. And then there's a lot of other things that are collected. And so specifically here, we're using AI to take a look at some of these areas: activity limitations, social vulnerability, sleep disturbances. Some of these items that you see here on the screen are pretty black and white, right? Polypharmacy. Well, Partners Health Plan knows exactly how many medications everybody is on because the PBM, the actual medications are all done through Partners Health Plan's authorization and payment. And even those that are over the counter are also collected by the care manager. So some of these items that we help to create more depth to the story for each person and the model of care, some of these come from claims, some come from assessment questions. But there are several that are coming more and more from AI because we're reading through descriptions and notes and trying to pick up on items for each person early. And items that as we meet a new person and do their intake, there's only so many questions you can ask in an assessment, but there's always things you're looking for and trying to figure out later. And AI is a very helpful tool for that. So some of these, what we've done is we've not been using public models. The last thing you want to do is paste this stuff into ChatGPT. It would give you amazing results, but you can't do that because you don't have business associate agreements. There are huge protected health information implications. And so can't be done that way. All of the work that's done is done on local servers with local models that learn from PHP's data and then are purged afterwards within a controlled environment, oftentimes without outside access to the internet, so that some of the risks of the PHI and the data, specifically with artificial intelligence and how it learns, is how we mitigate some of those risks. So typically we'll have it read through service notes for a person and learn, reading through different descriptions. We'll have a human in the loop to be able to help to validate. And I'll give an example here. This is around sleep disturbance. So defining what is sleep disturbance and having it read some materials on what sleep disturbance is, being able to pre-process those examples and tune them and pick out some of the better ones and leave out some of the outliers, tuning that model, and ultimately automating the process so that we're able to read through this and it doesn't require a whole team to go through every single time. And so we've used different tools. Here's one, a Python Spacey, that's used locally to identify. This particular one does a good job of picking out noun phrases and verbs and related terms to be able to identify with confidence if we found what we're looking for. And this example was sleep disturbance. So probably the ugliest slide in here, but how this goes, we have it, this is all de-identified, everything you see on the screen. It'll read through, and we can also have a person go through and read. Here, for example, this person tells us that they have sleep apnea. So being able to look for sleep disturbances, that's almost an easy one. There are others where it's not that easy and you have to be able to really read for context to figure it out. But a human reads and it helps us to learn which models to train on. And AI determines keywords, it determines context. Not all of these are good keywords, right? So it reads through this one and finds 2/15/2022 appears a lot. That might be important, but it's not, it's just a date. So being able to tune it and being able to filter through is really important. And then we're able to look at the models and figure out for each person a level of confidence. So in this particular case, we're looking for sleep disturbances. And sometimes the AI model will be 100% confident, it'll tell you. And those are usually the pretty good ones. Sometimes it's 75% confident. And this comes with the model and the work that we've been doing to identify, well, where's the cutoff? Is it 90%? Is it 80? Is it 65? And so it'll give you your confidence score, your not confidence score. This is really helpful to pick out people that help fit the model of care. So for each of those areas we looked at.
Yeah, I was going to say, and part of this is not diagnostic. This is for really stratification of the population. Again, because our population, by the way, may be nonverbal, may have very limited expressive communication skills. We use some of this, and some of this, by the way, some of this narrative may come from caregivers or family members. We use this narrative to be able to identify those people who may not otherwise be able to get screening, who then are the subject of additional attention by the care manager, who may then inform their primary care physician that we've identified a sleep concern in this particular patient that may not be able to come up during a 7-minute office visit.
Exactly right. And AI is not always right. Just because AI says someone has a sleep disorder doesn't mean they do. However, if otherwise the person is not flagged as having a sleep disorder and we don't do this AI work, then they wouldn't have any of the interventions or any of the supports necessary there. And we all know what happens when people's sleep is not what they would like it to be. Same is true with many of these. And so it's not the end all be all, but it's another tool that we use to help with careful consideration of the fact that AI is not perfect and always requires human intervention, but it's helping to flag things that we otherwise might have missed. And there's different types of machine learning that are part of the AI. We've been doing a lot lately with zero shot, where it's actually reading and scanning for context to help identify labeling of, and we can feed it, going back to 2016, we can feed it for each person 8 years worth of notes, and it can read it a lot faster than any of us can in a few seconds, which is really helpful. So one example is loneliness that we take a look at. And typically when you look at the AI models, and there's actually a lot going on, there's recently been a 66-page executive order from the White House. There's also been, we'll talk about some of the algorithmic transparency that's necessary. And so you want to know, what is the logic behind this? And so as you look at some of these algorithms, let's say it's looking for loneliness, it's looking for terms like lonely, isolation, alienation, desolation, seclusion. This is what it's looking for. Not a surprise. There's nothing in here that, you take a look at and go, oh my God, how could it possibly think that, social withdrawal and loneliness have anything to do with each other? They do. And so with traditional models of AI, they're sometimes just looking at keywords alone. That's not enough. And so here's an example, 2 real examples that came out of PHP. Example number 2 on the right, I sometimes find myself very lonely and unsure of myself. I want to get out into the community more, but I don't know how to go about finding different activities. Well, this one was easy. The person literally said they were lonely. So both of these are 99.5% plus confident that this is an example of loneliness to flag this person. The one on the left is interesting. I feel left out sometimes because nobody helps me be a train conductor. I've been wanting to be a train conductor since I was 5 years old. Many of us on this call could look at that and say, yeah, I mean, we may argue that maybe that is loneliness, maybe it isn't, but traditional machine learning would read that and it was only 23% confident that that person has loneliness. Whereas when Zero Shot read the context, saw words like nobody helps me and I feel left out, it's able to say, yeah, no, that probably is something worth further exploration for loneliness.
It also, and again, I have to say, having worked in this world long enough, a lot of the times when that kind of conversation is held with an adult in their 30s or 40s, the conversation gets dismissed because of the associated immaturity of wanting to be a train conductor at 35 years old. But the fact is, for this person with intellectual disabilities, it remains an aspirational goal for them that needs to be respected and acknowledged. And you have to actually dismiss the train conductor part of that and look at the feelings that are being expressed as a result of the aspiration that's important to them.
Right. Also remember, most of these folks live in the New York City metropolitan area and they have a lot of trains. That might be helpful for anybody else watching this. And so there's a good question that was just asked in the chat. What considerations are you making to protect individual data when utilizing generative AI? And you're spot on. Here's an example here. AHRQ just released a study that showed exactly what everybody's afraid of it showing, which is that there are algorithmic discrepancies on racial and ethnic disparities. That's one particular area of big concern for AI. Another big area of concern for AI is having that information leak out and become part of OpenAI's or Bard's public model. And right, and this is your protected health information. This is nobody's business but your own. And Partners Health Plan has all sorts of different controls and agreements to protect that. So as I said a little bit earlier, the last thing you want to do is paste this into ChatGPT because you've broken every rule, covenant, and control that you're supposed to have. So we've put some policies in place to make sure that the data is protected in environments where it is deleted afterwards, where any of the data that is used is de-identified before it goes into any of these models or algorithms. And as we see more and more coming with algorithmic transparency, that's helpful. So it's really two sides of the coin here, both of which are concerning. Number one, what are you doing with the data? Number two, is that fair to the person, right? Are they going to, I think it's Colorado has a law on the books that prevents AI when it comes to auto insurance because it was discriminating based on factors that really had absolutely nothing to do with the person's driving. And so we see that all the time. Here's an article out of Forbes, Racism in AI. Here's how it's been criticized for amplifying bias. It's a good headline. It's a worse article because it's scary without the controls in place. So Partners Health Plan has been really careful, and Medicaid has been really careful, both on the security side of the data and also recognizing that these data have consequences. So increasing transparency in the algorithm, diversity of research and leadership teams, diverse community groups, stakeholder awareness, making people aware when their data is used in a certain way, and then assessing the real world effects of these algorithms. And so with that, we reach our final slide.
So I guess if there's one, again, having spent a good part of my career on the insurance side of the business, working for a number of operating companies for a large commercial payer and another large Medicaid and managed care company, it's really about understanding the value in identifying people with IDD in your membership as a distinct population that needs stratified care that's based upon an IDD tailored model of care, both from the care management perspective as well as from the medical management perspective. Again, great example of that is during an annual wellness visit for a person with IDD, a choking risk assessment is probably more valuable than a cognitive risk assessment since you know they have cognitive impairment already. So the idea of making some slight modifications to what would be standard, because as I said earlier, what is standard of care is not always standard for the IDD community. Understanding how that model of care, working with the provider networks to understand the value of IDD tailored care, not just to the plan, but to the provider themselves. And, we're really excited about the very kind of distinct approach to AI that we're taking, independent of what, again, are the public chat GTP models. I think the sleep model, and I just want to talk about that for a second, the idea of training our model on taking the chapter of Up to Date and feeding it into our model about sleep, then taking all the people we have that already have sleep disorders and all of the language that's associated with the couple of thousand people with IDD who are known and have that diagnosis, training the model against that, and then taking the rest of the population and running it through that model to identify from a screening perspective those who may indicate the need for further assessment. No different than the screening population thing we do. Why does every child at 18 months get screened for autism? Not every child at 18 months has autism. The idea here there is not to identify autism, it's to identify the children who need further assessment. Again, 40 to 60% of them will never have autism. But it's important enough from a long-term perspective, from a AAA perspective, in terms of the person's life course, and this is as true for an adult with IDD as it is for a child, the population's overall capacity to participate as an active member of family and community, and finally, for appropriate cost controls and management of resources so that the people who need the resources can get them, and there's not preventable overutilization of resources due to our capacity to be, managing everything downstream.
Spot on. And so with that, we're so appreciative of everybody making it all the way through to the end. We'll be sending out a PDF of this, and we have Eric for some closing remarks. And here's our email addresses and that picture again that we had AI generate.
With all the wrong fingers.
Wrong finger.
Great. Well, thank you so much for the presentation. That was incredibly insightful. We really appreciate Appreciate you both taking time out of your days to share PHP's unique care model and then a ton of the data trends behind it and how effective it's been. Plus also how you guys have already integrated AI. Obviously, like you said, AI is not a new thing, but clearly you guys have done a great job integrating it already. So super excited to hear how it goes in the future. So thank you both for your time, and thank you to everybody who joined us this afternoon. I hope that you found the presentation insightful, and we'll see you guys next time.
Thanks for
everybody.
sticking with us.
Everybody. Thank you.
Thanks.
Thank you.
Bye-bye.
Bye.